All right, Joey, we're finally doing this thing.
Yeah, we are.
Episode 1 on the shoulder. We're going to be talking about shoulder osteoarthritis. But first, I really wanted to thank you for doing this. Really appreciate you taking the time, and wanted to give you an introduction because you are really well trained in the shoulder, and I just wanted to highlight that. So LSU Health Sciences Center, New Orleans for med school, right? And then we've got Boston University, where you did your orthopedic surgery residency.
Correct.
And then University of California, San Francisco for shoulder and sports.
Yep.
And then actually a second fellowship, which most people don't actually do, but actually a second fellowship also in shoulder elbow at the Florida Orthopedic Institute, which is in Tampa.
Correct.
I think, is that right?
Yep.
Okay, excellent.
Yeah, thank you. Thank you for having me. It's awesome to do this.
Yeah, man.
Yeah,
We've known each other for a long time.
I know.
Long
All the way
time.
back at LSU. That's
LSU
yeah.
at the
Health Sciences Center, the old hospital.
You got it. I was intern,
You were intern. I was third-year med student.
third year med student,
Yeah.
just kind of showing you how to do things,
Yeah.
right? Okay.
Still trying to show me.
Excellent. All right. So here we go, man. So first off, we're really going to focus on the shoulder today, and there's so much stuff to talk about in the shoulder. We really wanted to narrow things down to shoulder osteoarthritis. So, but probably the very first thing, even before talking about what is osteoarthritis, is actual shoulder anatomy. So kind of take us through like some basic shoulder anatomy.
Yeah, well, I mean, I think that when everybody thinks about the shoulder, obviously the surface anatomy is the thing you think about first, right? The deltoid muscle, the big muscle over the side of the shoulder that you tend to see when you look in the mirror. But there's a lot more that lies beneath, and I think we could get really into the details and the nitty gritty. But I think for all intents and purposes, people hear about common terms. We talk about the bony anatomy, starting with like the humerus, right? The humerus and the scapula are the two bones that make up the shoulder. Really, as far as the shoulder joint, the true glenohumeral joint is what's important with arthritis, and then there's the clavicle as well, which attaches to the chest wall as well as to the scapula. So that's kind of how the shoulder sits on the body, and it's interesting that the shoulder actually almost hangs from the clavicle, so it's actually entirely enveloped by muscle as far as the scapula, and that whole complex is just basically hanging on the clavicle by the AC joint and two ligaments that attach to the distal clavicle, or the end of the clavicle for lack of better words. But the point being is it's a really interesting joint. There's a lot of muscles around the shoulder blade. I hate to get into all of them because it's going to be a little too complicated, I think. But a lot of people think about the rotator cuff. I know it's sometimes a word they're not sure is it a cup or a cuff. It's a cuff of tissue, C-U-F-F, of tissue, and it's four main muscles that wrap around the humeral head and help control it in that joint. And so that's what that's kind of the main muscles when we think about the rotator cuff and kind of those types of injuries. But when we're talking about arthritis, we're going to be talking more about the joint itself, the glenohumeral joint. That means the humeral head and then the socket, so the ball and socket. And that's what's covered with cartilage, and that's kind of where the arthritis comes into play. So we'll kind of focus on that today, and we can always get into the details of everything else on another.
Yeah, definitely. Great start off on that. I think of it really like when I'm talking about shoulder anatomy with patients, it's like a golf ball on a golf tee. Yeah, so like really simple, and the golf ball has to balance on this golf tee.
Yeah.
And so the rotator cuff helps kind of compress and hold that golf ball on that golf tee.
Correct.
And then the shoulder blade is sort of moving, is the golf tee sort of moving underneath the golf ball to help keep everything together. And then the only bony joint between the rest of the arm and the rest of the body, like you said, is just strutted out like the clavicle,
right?
Like a control arm on a car, like a axle or something.
I think of it, I like the analogy of the jet engine hanging on a wing, and it's just hanging, at the under the wing, and it's just hanging on by those ligaments. So that's kind of how I think of it. But yeah, the same thing I tell my patients, it's like a golf ball on a tee. So you can imagine if there's something that's going wrong in the complex, imagine walking around, your house holding a golf ball on a tee and trying to keep that balance, right? Well, that's what the shoulder's doing all the time. And anything that can go wrong, and it starts to throw that off balance. And it is the joint with the most degrees of freedom. So it's not like your hip, where it's much more constrained and it's a tighter socket. Your knee, it's got a lot of play. So things can definitely get out of whack pretty easily.
For sure. All right, so let's go ahead. Let's move on to the main topic here, and that's osteoarthritis. And so you can get osteoarthritis anywhere, not just the shoulder, of course. You can get it in the hand, the hip, the knee, wherever. And so what is osteoarthritis?
I think people need to understand that, when we're talking about a joint, there's cartilage lining on the bones, and what osteoarthritis is basically cartilage loss. Right? When you lose cartilage, there are radiographic or X-ray findings that would indicate that you have arthritis, and that's where we kind of diagnose it. There's also clinical exam findings that would as well. But really what we're talking about is cartilage loss. So when you start to lose cartilage on the surfaces, which is it's a smooth layer on the ends of the bones that allows gliding. It's like ice on ice. But when you lose that, you start getting, a lot of the lumps, the bumpy feeling in the shoulder or the joint, whatever it may be. You start to get pain because the cartilage has no nerve endings and the bone does. And so then when the cartilage goes away, the nerve endings hurt because they're rubbing on each other. And so that's kind of where the pain comes from. And then you can expect things like stiffness in the joint and things like that. So that's kind of what arthritis is. Now, if you looked at an X-ray, there's kind of 4 radiographic findings of arthritis, and that would be joint space narrowing, and you'll see the joint get closer together on the X-ray, and that's kind of what we mean by that. You'll see osteophyte formation. So people hear about bone spurs in their joint. That is a true bone spur is what we're kind of referencing in that regard. We talk about subchondral sclerosis, which is really hardening of the bone. So you see the bone take on a very hard appearance, like very white, dense bone on the X-ray, and then subchondral cyst, which is basically cysts that form in the bone from cartilage cracking. The joint fluid will seep into the bone and form these little cysts. So it's not a bad thing when you hear, cyst is as bad as cancer. No, it's just. But it's a reflection of that cartilage loss. Yeah,
I think we'll definitely get into some of those changes when we talk about the X-ray. Arthritis, it seems like there's different kinds. You have rheumatoid arthritis and things like this. But I guess a good way of thinking about it, maybe you agree, it's just osteoarthritis is like a mechanical thing, right? Like more mechanical than anything else, where the cartilage wears out, that low friction, lubricating, shock absorbing, thin layer on top of the bone wears out, and then, as you say, then you get the nerve ending dense bone grinding on itself. Yeah, that is osteoarthritis.
Yes.
Right? Okay. Yep. Yeah, and so, and then that's and you can imagine when all that starts to happen. You can imagine all sorts of sensations will happen in the shoulder, the grinding, and all that kind of stuff.
You get
sure.
the crunch. You may hear like things crunching or kind of almost like a ratcheting feeling when people start to raise their arm with bad arthritis. It kind of like ratchets as they go up, and it's definitely notable. And that's kind of more maybe your painful popping a lot of times. And so people hear a lot of popping and things in joints all the time, but then that's when you start to see it become much more painful, like you mentioned.
Yeah, perfect segue into the next topic. So like subjective complaints. So people come into your clinic, my shoulder hurts, right? And one of the things that I talk to them about is there's a lot of pain generators in the shoulder, and sometimes it's really hard to narrow that down. And so so you mentioned a few things. Maybe rehash. How does shoulder arthritis typically present in a patient?
Yeah, so shoulder arthritis typically would present with some level of shoulder pain. Again, there are a lot of pain generators in the shoulder. A lot of times people are confused. They're like, my shoulder hurts, and they're pointing at their behind their shoulder blade or the right side of their neck or whatever it may be, because it is a huge complex. And I would say that with arthritis, people typically present sometimes with joint line pain in the back, and it's usually the back of the shoulder, but it can be in the front, but it's usually kind of that posterior back side of the shoulder, maybe some referred pain down, but that's the joint line kind of along the back side of the shoulder. And probably a lot of the reason that is because a lot of arthritis wears out the back of your joint, so people hurt on that side. And they get referred pain down the arm a little bit. You sometimes get some bicep symptoms, and your biceps is often irritated or inflamed with that, and that can go down the front of the arm. But generally, it's joint line type pain. The other thing you'll get is stiffness. So things you'll look for clinically on exam, you'll see almost the shoulder starting to tighten. And there's really only a few conditions that cause the shoulder to stiffen up. So if you have an X-ray that's completely normal and somebody is stiff, that's not arthritis. But if you have somebody who comes in who has an X-ray, who has a stiff exam, specifically, you'll start to notice that reaching up behind their back will be kind of like one thing that they'll lose first. When you start seeing stiffness on exam and then you get an X-ray and you start to see arthritis, well, those usually go together. So that's kind of one thing you look for as well. So pain, sometimes it's not as painful as you think. You just pick up stiffness on exam and you happen to look at an X-ray and see, yeah, you got some early arthritis. So, but that's kind of the things you look for.
Yeah, that's great. So do you find that the pain that patients describe tends to be more like deep-seated? Like it's, I feel like when they come to see me, it's sort of like they do kind of this thing.
Yeah,
it's like
they say it's aching.
Yeah,
kind of like an aching, throbbing type pain. And it's also if some people will take anti-inflammatory medicines. I tend to hear more when I ask patients who have arthritis if they take, ibuprofen or naproxen, one of these anti-inflammatories, if they actually get relief. And surprisingly, those not surprisingly for this scenario, but a lot of times people will be like, "Oh, I took that stuff, didn't help." But for arthritis, I tend to hear more yeses than nos, versus like some of the other conditions in the shoulder. So I feel like for the arthritis, it does respond very well to NSAIDs is what we call it, but like your ibuprofen, your Advil, those types of things. So that's another thing they'll commonly say. But yeah, that kind of like general like aching, in the shoulder is kind of what we expect.
Do you think that more sharp type of pain is less common with shoulder arthritis? I find that this is a little bit anecdotal, but like sharp pain, say the biceps, long head of the biceps, tendonitis, that tends to feel maybe more towards the outside, if that makes sense, towards the surface, towards the skin side, more sharp, and maybe even like rotator cuff or bursitis tends to feel more towards the outer side of the shoulder and more sharp than kind of this deep achy like arthritis kind of pain.
I would agree.
Okay.
Yeah.
So I want to ask you this real quick.
Sure.
About the neck. So I also find a lot of patients come with neck problems.
Yeah.
So can neck problems also overlap some of the pain of shoulder arthritis, or can it mimic that?
I definitely would tell you that neck can cause a lot of pain in the shoulder that's sometimes not well explained by something on your shoulder, and that's the tricky part about what we do is, I feel bad sometimes when I'm like asking patients about their neck because I don't want them to think that I don't believe that their shoulder hurts, but at the same time, the neck can often mask what's going on. You may think, hey, like I have this terrible shoulder problem, but actually you have a pinched nerve in your neck, or like a C5 radiculopathy, and you're getting this deltoid pain. And it acts like shoulder pain, and it is pain in your shoulder, but it's not the source of the pain, right? And so it's really challenging sometimes to work through that. And the hardest patients to deal with are when they come in and they have an MRI that somebody ordered of their shoulder, and there's a really tiny, small, like a 1 millimeter tear, but they hear tear in their shoulder, and you have to explain to them that this little tear is probably not the source of your pain. At the same time, they have bad disc disease in their neck, and they probably do have some radiculopathy component, which is nerve compression radiating down into the shoulder. And so those are really challenging patients. So we see a lot of overlap there. I'm sure you do as well, and those are the hardest ones to work through. And sometimes there are two problems, right? Some people have problems in both, and you have to work through that and decide which one is you're gonna prioritize, and then sometimes remarkably you treat one and the other actually gets better. So there may be some correlation there, being that one innervates the other, and then maybe it's just it's body position changes, things like that then take some of the load off of the other and make it feel better.
Yeah, I think you make a great point about one doesn't necessarily rule out the other. Like if you have neck problems, that doesn't mean you can't have shoulder problems.
Correct.
And in this day and age when we're there's a lot of patients coming through clinic, and you're trying to everybody wants to get added on to clinic and things like that, but you need to take the time to actually sort out, is it the neck, is it the shoulder, is it both?
Correct.
And that isn't always a quick clinic visit.
No, it's not.
Yeah.
I do a neck exam on every patient.
Same.
And just because
same.
I feel like you have to, and it does add time, but and it doesn't always mean you get the right answer, but you're trying to get as many data points as you can and make the best guess at what's going on with them.
Right. And one thing I'll mention to patients is you kind of have all these inputs, and the output is what you perceive as pain.
Right.
And so if you have input 1, which is your neck, and then input 2, which is your shoulder, and you don't educate people as to what those two inputs are for your total pain, and they get incomplete relief without explanation that you have two inputs of pain.
Right.
Like if you treat one thing,
right,
and they're wondering, why do I still hurt?
Right.
But if they know that, okay, well, sir, ma'am, you have neck problems and you've got bad arthritis on your shoulder, we need to address both of these to kind of bring all these symptoms down. Yeah. And that I find being able to go through that is helpful.
Yeah. And it's frustrating too for us, because as many people may or may not know, like I focus mainly on shoulder, and that's what I do. I don't treat necks per se, but I get people to the spine doctor, right? I might get to the neurosurgeon or orthopedic spine surgeon or a pain doctor to do injections for the neck. But the problem is I don't do that. So I can treat my part and try to get them taken care of, but it does make things difficult when you have those multiple potential sources of pain and you're trying to treat all at once. So it can be challenging. It definitely is.
So one thing, maybe one last thing on like actual patient symptoms. There are these pops. You mentioned these pops in the shoulder, and I think people feel popping all the time in their joints.
Yeah.
For shoulder arthritis, it's just like a mechanical thing popping, but are the pops dangerous? I feel like I get that question, maybe not directly like that, but that's sort of what they're wondering.
Yeah.
You know, they feel a pop and they freak out a little bit.
Yeah. Yeah. So a couple things regarding popping. So generally popping in your shoulder, if it's non-painful, is really not something to worry about. With arthritis specifically, it's not necessarily something to worry about either, but it's a mechanical symptom, right? And we mentioned the bone spurs. So the humeral head takes on more of a square shape once you start having all these bone spurs. And so you have almost a square peg in a round hole, and you're kind of clunking around in the shoulder, and that's what's happening. Some people almost describe it as, I feel like my shoulder's popping out. You're like almost out of socket. And it's actually the opposite. If anything, your shoulder's too stiff, right? And so, but they get these sensations that like my shoulder's popping and it's something, something's going on. They're not really dangerous. They can be painful though. And with arthritis, it's more the arthritis pain, I would say. If we're talking about soft tissue or things like that, those would be other scenarios where a painful pop might be something to worry about versus non-painful pops, which are generally not as worrisome.
Yeah.
The other thing I'd like to add, we talked about arthritis. A lot of people will say, hey, well, it must be, they chalk everything up to arthritis. They say, oh, I'm getting old, I must have arthritis. Arthritis is a genetic problem, right? I mean, and you put it with the right environment and it can be expressed earlier, but there are plenty of people who live all their life and don't have arthritis in their shoulder, right? So patients shouldn't come in thinking like, oh, well, I just have arthritis, because you might not ever have it. I see 90-year-old people all the time who don't have any arthritis in their shoulder. And I see, 50-year-old people who have terrible arthritis in their shoulder. So it's definitely genetic. So if you have family members with arthritis, especially immediate, don't be surprised if it pops up somewhere in some part of your body in your life, right? It's usually multiple places.
Yeah, I think great point. I actually want to go into that a little bit when we start talking about imaging next, about this blanket diagnosis a lot of people tend to get is just arthritis. My shoulder hurts. Maybe the person who is checking the patient out isn't quite as experienced or trained up on shoulder exams and shoulder conditions, and so they it's just must be arthritis,
like wear and tear, which is really a term I hate, but
perhaps it's not a great term, but it's one that I feel like I have to use a lot when describing other things, because there's a lot of like cumulative wear and tear that happens in the shoulder, like with rotator cuff and tendinopathy and stuff. But
arthritis is really not a wear and tear per se. It is true. And don't think like, oh my God, I have this disease, but it is a disease. I mean, it's not a terminal disease like cancer potentially could be, but it's a disease, and it's genetically, you're genetically predisposed to it. It's just very common, right? So
yeah. Well, you mentioned a genetic predisposition. Let's talk real quick about rotator cuff arthropathy.
Sure.
When we were talking off camera, we didn't quite get into this, but there's another type of, like a pattern of arthritis called rotator cuff arthropathy. So tell me what that is.
Well, I'll start telling. So I want to start by going to what regular shoulder kind of glenohumeral arthritis is, and then we'll kind of talk about the difference in what rotator cuff arthropathy is. So generally for glenohumeral arthritis, the vast majority of those people do not have full thickness rotator cuff tears, right? So most of those people, probably 90 to 95%, have a normal rotator cuff, relatively speaking, meaning, if you got an MRI, there might be a little partial tear, which almost, so many people have as you start to approach 60 and 60 plus years old. It's very common. It's almost expected, right? But so for true arthritis, it's just cartilage loss in your joint. Rotator cuff arthropathy, however, is different in that the shoulder develops arthritis due to the size of rotator cuff tearing that you previously have, and the shoulder starts to migrate in a certain direction. So you usually lose if you lose two of the rotator cuff tendons, the supraspinatus and the infraspinatus, which is one right over the top and one kind of in the back and the top, kind of posterior superior, your humeral head starts to migrate up and back. And so you start to wear out the posterior superior, which is up and back part of your socket. And when you do that, you start to narrow that space because your deltoid muscle is pulling up on your arm, and that space starts to go away. So you're wearing out the top of the humeral head and the top of the joint, the socket. So you actually wear out in a very different pattern than somebody with primary arthritis, who tends to wear more down the middle with no change on that top portion. And we can talk about what that would look like on an x-ray.
Yeah, so that goes back to like the golf ball and the golf tee example. Yeah. So the golf ball, like if you turn the golf tee sideways like this, the ball is going to fall off.
Yeah.
But with enough compression pulling the golf ball into the tee, the ball will stay seated.
Correct.
And that's what the rotator cuff does. Then, so we're talking about tearing to the extent where you lose that.
Yeah.
But what gets confusing is you think gravity is going to pull it down.
Right.
but actually what happens is it migrates up, right? Because it's deltoid.
Your deltoid's pulling straight up. So I always draw a picture for patients, and I say, look, the job of the rotator cuff is to hold that ball into the socket, right? And then if you lose that, the deltoid muscle is pulling straight up. So you need that force pulling in as well as the force pulling up to raise your arm. But if you lose this, then this takes over, and so your head just starts to migrate up, and that's what happens.
And then it starts to edge load. So you think the golf ball's perfectly seated, and there's a lot of area, that the weight is distributed on. And so when that ball starts migrating, you get some edge loading, and then just wears it out in that area.
Wears out in that specific area. Right.
Yeah. So that's the two big differences, I think. A little bit nuanced there, but important for patients to know, because those are treated completely differently. That we'll get into for sure. Yeah. Okay. So, all right, let's talk about imaging. So when it comes to diagnosing shoulder osteoarthritis, how do you start off your imaging? What do you get?
So I get 5 views on X-ray. That's just my routine. Not everybody does that. I would say if you had to pick, there are 3 main views that you would want to get, which would be a true AP of the shoulder, which we call a Grashy view, a scapular Y view, and an axillary lateral. And those
when you say AP,
right,
you're saying
a true AP.
So looking straight
anterior to posterior, right?
Anterior to posterior.
Well, so it's a good question. So the shoulder. So I get 5 total views. Just to go through all 5 of those, it would be an AP, a Grashy, which is a true AP of the joint line, and then I get a scapular Y, axillary lateral, and I get a weighted abduction view. I like that view. I have the patient hold about a 5-pound weighted glove in their hand and abduct the arm, which means kind of raising it out to the side a little bit, and it gives me almost a weight-bearing view of the shoulder, which helps me look for any joint space narrowing, which would indicate early arthritis, or it shows me the dynamics of how the humeral head or that golf ball is staying on the tee. And so it does give me a good bit of information, so I do like that. But the 3 main views would be a Grashy, which is a true AP of the joint. Now you may say, well, AP means the beam is in front of you and it's shooting straight to the back, anterior to posterior. Right. However, the true AP of the shoulder, the shoulder blade sits at a 30 to 45 degree angle in your chest wall, so you really have to angle the beam on that axis to get down the joint. So that's technically the difference between, if you go to the emergency room and they get an AP view of your shoulder, you're going to have this kind of angled view of your shoulder joint. You never really know. And when I see reads that like, oh, a patient has arthritis, I'm like, you don't really know if they have arthritis because you can't even see the joint, right? So it's a very different view than what you really need to diagnose true arthritis.
Yeah, I cannot agree more on that. Yeah. Everybody's conscious about cost. So some patients will come in, their primary care doctor has already obtain some x-rays, and usually there's just a standard button you click, click shoulder x-ray, right? And that doesn't include a lot of what you've described. And because it doesn't include these views, you don't get all the information that you need. And just like if you go shopping for a car or something like that, or there's a I don't know, you go to a museum and you're looking at, sculpture, a statue or something, and you're looking at different angles at things, right? You're looking at from different perspectives, and that's what these multiple views are that you're talking about, or these different perspectives on the shoulder. Each one has its role, and each one provides its own information for you to make a good decision about what their diagnosis is, to be precise as possible with the diagnosis.
Correct.
And then you can figure out where to go from there.
Yeah, I think your point about patients coming in with x-rays from outside, it's helpful sometimes, but sometimes it's a hindrance for the reasons you mentioned. I like having my own views. I have x-ray techs in clinic. They're very well trained to shoot the views that we want. And so it's hard to justify having somebody get new x-rays. And so usually what I do is I look and see what they have, and I just supplement what they don't. So if they come with say a regular AP of the shoulder, then I don't get that one. Or if they come with the AP and scapular Y, then I get the other 3 that I get. So that's what we typically do. But again, if you're in a scenario where you're like, my shoulder really hurts, my primary is going to refer me, why don't I just wait and go see them, and I can get the x-rays in clinic, with the orthopedist, because typically they're going to get specific x-rays that they want. And that same applies to like neurosurgeons with spine. Sometimes they want dynamic views and flexion extension, things like that. So I think that it's better to kind of go ahead and get to the specialist and have them decide what they want.
Right. So next big question. Very commonly, patients will come in and just say, well, can I just get an MRI? Why do I need, can we just get the MRI scan?
Yeah.
So can we just go straight to an MRI? Why do we need both?
Yeah, it's a good question. I mean, I oftentimes find it amusing how many peer-to-peers I have to do on the phone to get MRIs approved, whereas they come in from their primary care and half the time they have an MRI. I'm like, how did this happen already?
Right, yeah.
So I've documented so many things and I still can't get it approved. No, the MRI is a great study. It shows a ton of soft tissue. It's good for bone. It's not the best study for bone as far as bony anatomy. If we're being very specific for the bone, a CT would probably be even better. A CT scan or X-rays are good for bone, obviously, because that's what we're looking at. But the MRI is good. It shows everything in the shoulder, right? The soft tissue, the vasculature, the cartilage, and depending on the quality of the MRI, you may see that stuff in more detail versus a different MRI. What people don't realize though is that we treat things based on X-rays. So if I treated somebody with for shoulder arthritis and I do a replacement on them, I don't MRI their shoulder every time they come back to see me, right? We get X-rays. So we need something to start with and we need to diagnose with, and then we work off of those films for follow-up, right? So that's how we, it's kind of a quick and easy way for us to monitor progress or decline. Mm-hmm. And so that's why X-rays are so important. That's what we use in the operating room. That's when we're fixing broken bones, right? So we need those X-rays. And then the MRI is great for the soft tissue, but for arthritis specifically, you don't necessarily really even need it, right? Because if you get an MRI with arthritis in your shoulder, it's going to look like a bomb went off in your shoulder. They're going to read degenerative labral tearing, significant
Right.
cartilage loss, like all these findings that scare the patient almost. Because like, oh my God, what's going on my shoulder? It's like, you really just have osteoarthritis, but all that is, it's all encompassing all those things, right?
Yeah, that happens so commonly in my practice also, MRI scans with arthritis. And it's great that patients have access to their reports, but they often need some help to interpret what those reports are saying because there's a lot of tears, there's a lot of degeneration, scary sounding words.
Right.
And then by the time they get in to see you, they're all freaked out because this MRI has said all these terrible things that actually just mean arthritis. Right. So but yeah, so I guess is MRI needed when the diagnosis is clearly arthritis? Probably not.
Right. The times I use MRI for arthritis are when I have patients who have I can tell they have an intact rotator cuff on exam. They have a really strong shoulder. And you could tell there's a little bit of narrowing of their joint space. And in that scenario, I tend to notice that, if they're having pain that's a little bit out of proportion to what you might expect, in that case, I typically I'll get an MRI to look for maybe there's more extensive cartilage loss, or just like there's potholes in the street, right? Mm-hmm. Your car will ride over some of them and some of them it doesn't. Well, if the car falls into the pothole, that's going to be seen on an X-ray. But if the car is gliding over the potholes, you're not going to necessarily see that on X-ray because it's holding that joint space open. So in those scenarios, if I'm suspicious for early arthritis or maybe some focal areas of cartilage loss in the joint, I will get the MRI in that scenario.
Yeah. Especially, these patients, you're working to figure out their source of pain, and sometimes, things you suspect things and the X-ray doesn't quite tell the whole story. So, maybe you're catching somebody with earlier arthritis or something, or that very localized arthritis. That tends to happen to me as well. Yeah. Okay. So,
and to just to that point, you might ask, well, why is that relevant? Well, even if it's as much as, well, look, I want to, we'll talk about treatments, but say they want a shot in their shoulder for pain relief, right? Well, if you know the process is in the joint, right, the arthritis, then we're going to inject in the joint versus if it's a rotator cuff problem, for example, we're going to inject over the rotator cuff. So it helps guide our treatment.
Yeah, great point. Definitely something we're going to touch on. So let's move into treatment. And I think one of the big questions we have to ask is, when we're thinking about treatment is osteoarthritis dangerous? Is this dangerous to, I don't know if dangerous to ignore, or let's just say, okay, is it just dangerous in general? How about we go with that?
It's non-life threatening.
Okay. Right. Yeah.
To summarize it in just a few words.
It can be life functionally altering though. Yeah.
And it's interesting because everybody's different, right? I mean, you have these people who come in who are such high performing people when it comes to I want to do this, I want to do that, I got to play this, I got to do that, I work out this many times a week. And those people are going to be affected by just a little bit of arthritis, probably way more than somebody who's I wake up every day, I go to my desk job, and I go home and I turn the TV on and flip through the channels. I mean, and that's the truth. I mean, so you're going to notice that, the activity level is what really affects, I feel, or what really affects people's quality of life, or how arthritis affects their quality of life, is when you kind of look at how active somebody is. Now, you said dangerous, again, not life threatening, but definitely life altering. And I wouldn't say ever that it's dangerous to ignore, with the exception of, I do get occasional patients that finally make it in to see you because they're finally I should probably get this checked out. they come in and their x-ray shows a significant amount of bone loss, because what happens with arthritis is the joint gets eroded away. And so eventually you can actually erode that socket, that golf tee, down to where that triangle of the golf tee gets smaller and smaller. And that triangle is important for fixation if we're talking about replacement of your shoulder. So if you don't have enough bone there, you start to run out of real estate to put an implant in, right? And so that is where the shoulder is unique, different from, and you get this kind of wear maybe in the knee or hip, but those are much larger surface areas to put implants in, versus the shoulder socket literally is like, in some patients, it's just bigger than a quarter, right? It can be tiny. So you got to remember that bone is the ultimate commodity when it comes to what we do. And the more you lose, the harder it is for us to treat it, right? So that's the only scenario where I say, it's not dangerous per se, but it can affect ultimately what can be done for your shoulder. So if you come in and you have that scenario, I tend to follow those patients. If they don't want anything done, but they just want to know, I say, well, look, come back in a year and let me get another x-ray. We'll have another data point to compare to, right? Or 6 months, even if it's their first time presenting. And that way we have 2 data points to say, well, look, this is what your shoulder looks like now. It's not so good, but we got a shot 6 months later and it still looks the same. So we're not progressing too rapidly. And that kind of helps kind of follow those people.
Right. Okay. So, so that was sort of like my next question is, and you address that. Does it progress? Sounds like the answer is yes.
Yes,
it will. It will progress.
Yeah.
How fast are we talking here? Are we talking about? Oh my gosh! Well, I have an osteoarthritis diagnosis of the shoulder, so now I've got a solid 1 month before this whole thing falls apart, right? Or
it's not gonna be like that, but it can progress quickly. It just depends on what you're doing with it, honestly. So the whole like genetic predisposition, right? If you put something in the right environment, right, it's going to express itself, right? So if you take somebody who says, well, I have some shoulder arthritis, and you say, okay, well, I'm going to go to the gym and bench press 300 pounds, 2 days a week for reps, and then I'm going to go shoot an x-ray 4 months later, you're probably going to see progression of your arthritis, right? Versus somebody who does not do that, right? So you put the genetics with the right environment, it's going to progress more rapidly. Now, the duration of time is hard to say whether it's months or years. So that's why when I see a person for the first time with arthritis, that's bad enough that when I look at an x-ray and I say, your shoulder is bad enough you could have a replacement, but they're not symptomatic enough that they want a replacement, I at least have them come back one more time in 6 months to a year to shoot another x-ray to make sure we're either A, staying put, or B, we're progressing. And that's kind of my way of determining the time it takes to progress. But generally speaking, it would not be overnight. But again, those people, I have a patient recently came in, lifts a lot of weights, and x-ray 6 months ago to now, significant progression.
Yeah. So it seems like I agree with the surveillance like that, but there's probably a high percentage of those people will also notice changes in their symptoms as well.
Yeah.
Like if their joints starting to go,
yeah,
like early in the year it's fine, next year it's hurting a little more, then it's probably more likely than not you're going to see some additional change on their x-ray probably. But it's still, I would imagine, just a statistics game at that point. Yeah.
I think it's patient tolerance too. I mean, you have these people who come in who are just like hard outdoor workers who just like live on a farm and they're like, it's just my shoulder is stiff and it hurts. They don't think anything of it, right? They're just, it is what it is. And so they come in to finally see you like, holy cow, where have you been? This x-ray's terrible. And those scenarios I think are interesting because then you have other people who like the littlest thing and they're like, what is that, right? And so it could be that scenario where like somebody comes in and they've had this forever and they're just like, I never really thought much of it. I just thought it was getting old. This is what it was coming.
Right. Excellent. Okay, so the treatment. So even if you're seeing progression of the arthritis, I guess the question still is, do we need to treat this? And ultimately, it seems like that really comes down to what the patient perceives, right? Like what is their function? What's their quality of life like? My x-ray is getting worse, but my symptoms aren't that bad. Probably that situation is not very common where I'm okay with my function, I'm okay with my quality of life, and my x-ray is looking absolutely terrible.
Right.
Like that probably doesn't happen very often.
It's not often, but it's surprisingly, it does happen intermittently. Some of the older patients come in and they're like, doesn't hurt them that bad, terrible looking x-ray, like, I'm fine, I can get it up to 80 degrees and I'm happy with it and I do what I want to do with it. And I'm like, okay, well, I tell every patient, this is not your heart. It's not going to kill you, right?
Yeah.
Right. If I was the heart doctor and you had a bad heart problem, I came in and said, if you don't do this operation tomorrow, you're not going to be here the next day. That's different. That's never the case with arthritis, right?
Yeah.
So that I just reassure them about that, and then deciding to treat it is a conversation, right? It's what your goals are, what your quality of life that you desire, what that quality of life that you desire to be, and just making those decisions as a discussion.
Yeah. And I find these discussions are easier when you've met with the patient more than once. You've had, it's not your first visit with the patient. Maybe you've seen them once, twice, or once to the second time, third time, and they start to trust you a little bit. They start, you kind of go through this process with them a little bit, and that just kind of helps them through it all, I guess. I guess is a way of looking at it. All right, so let's talk about treatments now. So we have, clearly non-operative and operative treatments, right? So let's talk about non-operative treatments.
Okay. Non-operative treatments are a do nothing, right?
Right. Yep.
You have arthritis, and if it doesn't hurt you that bad, don't worry about it. Just live with it, right? So living with it, right? Number two would be anti-inflammatory medication. So people typically say, well, what's an anti-inflammatory? Or an NSAID is what non-steroidal anti-inflammatory. Those are going to be medicines like ibuprofen or Advil, Motrin, which is ibuprofen, those types of medicines, naproxen, which is Aleve, right? Then we have some prescription versions, Mobic, meloxicam, those types of things. So that's your kind of non-operative, pill form of treatment, right? Taking pills. There are injectables, right? So we talk about steroid shots. People hear about steroids, or cortisone is a common, generic term that we use. But steroid shots are very common. They're good for arthritis, but we talked about specifically in the joint, right? That's where the problem is, and that's what we mean by a cortisone shot for arthritis in the joint. And then there are other injectables that can be used. There's viscosupplementation, which is hyaluronic acid injection, which you hear a lot about used in the knee because it is FDA approved for the knee, and insurance companies do pay for it for the knee. However, they do not pay for it in the shoulder. The shoulder is not considered as much of a weight-bearing joint per se, but there are some smaller studies that do show that the hyaluronic acid injections could be of some benefit for the shoulder. It is the same arthritis type of thing. And those, I generally, for me, I try, because it's out-of-pocket cost, and it's usually a series of 3 injections, and many companies' versions of it, I try to get sample injections truthfully for patients because I feel like it's, I'm like, it may help, it may not, but I hate for you to be, paying a ton for this and not getting any relief out of it. So I try to do that when I can. And then there are some injectables that like PRP that you hear about, which is basically your own blood that you get drawn. It gets put in a centrifuge, it's spun down, and the tube basically breaks up into several layers of your blood, and you're injecting the platelet-rich plasma portion of your blood back into the joint. There are some, that's an option. Again, that's another out-of-pocket cost, right? And that's going to be a cost set by the provider. Whoever the provider is, they're going to say, well, it costs this much money because it's aspirating your blood, which is, I'm giving you your stuff back, but I got to do this process of taking it out, centrifuging it, putting it back in. So that may be an added cost that you'd have to be anticipating. And I don't routinely do those. I send those out for people who typically do PRP. And then the last thing I think you probably wanted to ask about was people hear about stem cells, right? Like that's kind of like the
that's the
right.
trendy. Yeah,
I would say it is just that trendy, right? Nothing. The way I always kind of think about it is, if you have really bad arthritis in your shoulder, there's nothing I'm going to put in your shoulder from an injectable that's going to cause your shoulder to then go through this, magical reconstruction of the cartilage is coming back, right? We're going back to the way we were when we were born, right? It's not happening, right?
One of the things, when especially with the structural change, not just losing the cartilage, but like the actual structural changes regarding the shape of the humeral head or the ball part of the socket and the shape of the golf tee, the glenoid. You actually get changes to the shape,
right?
And so, how is an injection going to change that mechanical environment?
Right, it's impossible. So So if people come to me and they say, yeah, somebody offered me stem cells, I'm like, please save your money, for this scenario, because this is not it's just for arthritis. This is a mechanical change to your joint. The stiffness is from mechanical changes in your joint. The crunchiness is from mechanical changes in your joint.
Right.
There's no injectable fluid that we're going to put in there and it's going to revolutionize the inside of your shoulder to make it go back the way it used to be. It's just not going to happen. So don't spend it, because generally speaking, if you want to talk about cost, stem cell costs that are set by the provider as well, right, are generally the highest cost of all of this stuff, right? All the injectables, right? So cortisone is covered by insurance. Visco supplementation, the hyaluronic acid is not for the shoulder. PRP is not for the shoulder. Stem cells is not for the shoulder. And you can easily rack up a bill with getting stem cells in your injection that probably costs more than you're out of pocket for your surgery if you had it, right? So just unless you have just money to blow and you are that adamant that you don't want surgery, I would advise against considering stem cells for your shoulder for arthritis.
That's my general impression so far. Not that there's good work being done. Maybe there's a lot of research being done. You could, but a lot of those studies seem to be at big academic places and things like that, where they have. I could be wrong on this, but I want to say it's you are not allowed to expand stem cells outside of like some sort of like a study, you know, like an IRB study or something like that. But I'd have to double check that for sure.
Don't quote them.
Right. Let's go back to cortisone shots for a second. You brought up this interesting thing where there's different parts of the shoulder, right? You've got the ball and socket, the glenohumeral joint. You have actually the space right above the rotator cuff called the subacromial space. And that is a completely separate space, a different room of the house. You have the AC, a small collarbone joint where the clavicle meets the shoulder blade. And then you got this biceps tendon sheath. So I usually tell people there's about 4 different rooms to this house.
That's true.
And so a patient will come in and they've had an injection, right? And I'm sitting here thinking, well, okay, where did the patient have the injection? So I'll ask them, where did they, do you know where? And then it's usually in the back. Well, okay. And that's fine. That's again, an educational thing. But the location of the injection is very important, because if the person who originally saw the patient did an injection to the rotator cuff area, the subacromial space, and their pain generator is from arthritis in the shoulder joint, it doesn't seem like we can expect them to have any pain relief.
Or as much, You occasionally, I think, just because steroids get systemically absorbed to a degree, I mean, you're going to get some pain relief, but generally not expected to be a lot. And I do notice specifically when I inject people in the joint who've had injections in the subacromial space, for arthritis, generally speaking, they get a lot more relief if it's in the joint. Right? Makes sense. So the shoulder's got a lot of places, right, that you can inject 4 spots, like you mentioned, and 4 main spots. But the problem is when they say I got an injection in the back, well, you can aim at the joint or you can aim above the joint, right? And if the shoulder is truly arthritic, like I mentioned to you, and there's no real rotator cuff tearing, then there's no communication with the joint from the subacromial space. So you can inject in the subacromial space, and that shoulder is fully contained by the rotator cuff, so that medicine is not getting into the joint. Yeah, exactly. That's exactly my point. Try to emphasize that to the patients as well. And and so the shoulder joint it's not a small joint. It's like a medium joint, I guess you could say. But it's can be tight to get like an injection in there. So do you feel like ultrasound can make that more accurate, perhaps? I feel like ultrasound is good for that scenario. However, the 2 spots of the shoulder that are probably the best used or have the best use for ultrasound would be the biceps groove down the front of the shoulder, because the biceps just contain a little sheath of tissue. And there's been studies looking at this. Hitting that blindly is like 10% chance. Right. So if you're getting a bicep sheath injection, you're best getting that with ultrasound. The last thing will be the AC joint. It's a small joint. Again, you may hear a lot about shoulder AC arthritis, but that's not your true shoulder joint. But that little bump on top of your shoulder, on thinner people, you can feel it. You can often drop in with a needle. But if they got any soft tissue layer up there, it's hard to feel, and you might just be poking away at it trying to get it in. So your best use super ultrasound for that. And then if you're, I do think that you could potentially be better off using an ultrasound in thicker patients who have, the shoulder can be deep in there, right? So if you can't quite get there, you might have to use a longer needle or things like that. So you might want to use an ultrasound in those scenarios as well. But routinely, if you scope enough shoulders, as you and I do a lot, it's certain landmarks, and you pretty much know you're in. I can't disagree with that. And, in well trained hands, you can accuracy is usually pretty high. My personal preference is to do it under ultrasound as well, but I'm not going to sit here and say people can't hit the joint without an ultrasound for sure. It's often reassuring when you've done a shot in the joint and you finally scope their shoulder and you're like, there's my shots in their shoulder joint. Nice, yeah. And also, so you mentioned these out-of-pocket injections as well, like for the visco injection, the platelet-rich plasma, and for sure, I would imagine if
you decided to get a stem. I'm going to use air quotes because I think the Academy actually wanted to change how that's presented into like mesenchymal signaling cells, perhaps. I don't know. Did you come across that?
I did not see that.
So there's a stem cell, which is a pluripotent cell, meaning it can literally change into any cell of the body, anything.
Right.
And so people call that an MSC, or the MSC, mesenchymal signaling cell, which means the cell acts, it signals in the stem cells to migrate. So anyway, if you do an MSC injection, let's say that, and you're paying hundreds of dollars, if not thousands, I would imagine you're using an ultrasound. If
you're paying for that and they're not using an ultrasound, I would say you should ask for one.
Yes,
that money is being injected into your shoulder, and you want to make darn sure.
You want to make 100. You want to be 100% sure that your $5,000 shot is going exactly where it needs to go. Right. Exactly. Yeah. Okay. All right, that's great. Okay, so let's talk.
And it is funny. You said 5,000. I mean, hopefully, you're not spending that, but you are. We're talking about four figures for an injection of stem cells. So.
I've seen menus, and they've been in the substantial thousands.
Yeah. And it's like I said, you could be spending more on that than your actual operation.
Let's talk a little bit on PT. Okay, so I get a lot of eye rolls with PT. I personally find it probably a little more helpful for non-osteoarthritis situations like bad scapular issues, rotator cuff issues, things like that. Is PT worth doing for osteoarthritis?
Good question. So, kind of like you mentioned earlier, if you go back to the analogy of the golf ball and the tee, and the whole idea is to balance the shoulder. I think that's where PT is most helpful, right? But that's not the case in arthritis. With advanced arthritis, PT's really not been shown to be very helpful. It actually, might hurt a little bit because they're pushing on a very stiff joint that's not likely to get much looser. If you do have a joint though that's mildly arthritic and you're getting very early stiffness, I have noticed a few patients, or in those specific patient groups, that you get them in with a therapist, they get maybe 10 degrees of motion each plane back, and they can get, the joint's not fully socked down. They haven't had those significant anatomical changes that affect their motion to a significant degree. Those patients tend to get a little bit of relief out of therapy, and they tend to be happier with having just a few more degrees of motion, because stiffness hurts a little bit, right? It's uncomfortable, and stiffness can lead to other things like impingement and things in your shoulder. So I think that in that case it is helpful. But advanced arthritis, no. But you'll still fight with insurance companies when you have a horribly arthritic shoulder. There's occasional ones. I'm not going to name names of the companies, but there is one specific that stands out in my head. They're like, well, has the patient done any therapy? And I'm like, no, because this is advanced bone-on-bone arthritis, and the data would suggest that is not helpful. And they're like, well, although we agree with you, there's a company's policy for them to try therapy. So here's what you need to do. They need to go to the therapist. The therapist needs to write that this is not going to be better, this is going to be harmful or hurting the patient and not beneficial, and then resubmit it so that they can get approved for their surgery. I'm like, really? That's what we have to do? But that's the way the world.
Yeah, that's the game. Yeah, that's the game we got to play, it seems sometimes.
Yeah.
Let me ask you about this particular situation. So,
sure.
It does seem like younger males, say 40s or so, which is like me, I guess you.
Yeah.
But they still have a lot of. They still expect a lot of demand out of their shoulders. They're working out, they're doing a lot of things, and they might start getting some arthritis, especially some of these guys who might be more genetically predisposed.
Yeah.
And they start losing a little bit of motion, with a little bit of arthritis. It seems to me like those particular patients can really benefit, like you pointed out, because in the day-to-day life, we're only utilizing a certain percentage of our available range, right? Like
Correct.
We're going to work, we have a desk job normally, whatever. But then when we go out and we mountain bike, we lift, whatever, those types of things, we start getting into those more extreme degrees of motion that we need for whatever activity
Correct.
we're doing, throwing a baseball, football, something like that. And so maintaining that more end range seems to be really beneficial in those people, if at all possible.
Especially throwing. You hear that complaint a lot. Like, I can't throw the ball at my kid. And sometimes
Yeah.
you just have to break the bad news and be like, man, this is bad enough. You're not going to throw the ball at your kid, you know. Or sometimes in that scenario, like you mentioned, it's just a little bit arthritic. You might, right? So you get a little extra range of motion. 10 degrees of, you know, this throwing position is a big difference, right? You get your hand behind your head versus in front of your head. You can't throw a ball too well from the front, you know,
Right.
in front of your face.
Right.
So that might be a scenario where it would be helpful.
Yeah. Okay. Yeah. That's yeah. I've personally found that helpful to go through some of that with patients. Okay. Do you want to add anything on non-op that we've missed?
Just to give you some, you hear about cortisone. Well, and I mentioned NSAIDs, non-steroidal, just so you kind of understand the difference. Cortisone is an anti-inflammatory also, so it is a steroidal anti-inflammatory. So it's, you know, there's also steroid pills. So those are steroidal anti-inflammatories versus non-steroidal. So sometimes you'd be like, well, I need an anti-inflammatory. We're actually talking about the same type of goal, right? It's to decrease inflammation. They're just doing it two different ways. So still the same kind of mechanism, for lack of better words, or still same goal as decreasing inflammation. Just there's non-steroidals and there's steroidals, and the steroids can be pills or injectables in this case.
Yeah. Okay. That reminds me. So how often do you let patients get cortisone shots, by the way?
Good question. I don't personally, I don't like to let them get cortisone shots more than every 3 months, and this may just be a, you know, an orthopedic.
Is that dogma? I don't know.
Right?
Yeah.
But I would tell you that I have seen patients who go to other places and they come see me and they've literally had a shot in their shoulder every month for like the last year, and I'm like, ugh, I don't
Yeah.
like that.
Especially maybe if they're young.
Right. That really makes me
good.
worried. Yeah. So I tell patients, and again, I don't like to do it more than 3 to 4 times a year. And that's once your joint has reached end stage, like you're arthritic. Like, so if you're going to be like, hey, look, I don't want to have surgery right now. It's not a good time in my life. I just want to ride this into the ground, like, you know, drive the car till the wheels fall off, for lack of better words.
Right.
Then fine, we'll do a shot. We'll do it no sooner than every 3 months, right? And so that's kind of how I do it. But if you're getting shots and it's helping for 3 days, why are you like? Is that really worth it? At that point, you're like, okay, it's time, right? I mean, your body's talking to you.
Right. Yeah. So I know we're talking about osteoarthritis this show, but I feel like this is important to get across. When it comes to tendon issues like rotator cuff or let's say tennis elbow or something, I feel like these repeated cortisone shots are just not good.
They're not. They're overutilized.
Yeah.
And so I would encourage patients, you know, anybody who watches it, right? If you go to the doc and you just go, hey, I just want to come get my shot, but you don't really know why you're getting that shot, right? It's like, well, why are you getting your shot? Well, do you have a rotator cuff tear? Well, don't keep getting shots because it's really bad for your tendon. And if you ever try to fix it, the likelihood of you healing that goes way down with multiple injections. So, and even some studies, one injection can negatively affect it, but definitely multiple, especially within a year of surgery. So you don't want to be I'm just here to get my shot. You're destroying your tendon, right? And you're also decreasing the likelihood that tendon will ever heal if you operate on it, right? So the tissue quality gets definitely significantly affected by the steroid.
Yeah, agree with that. With that. And that happens to me a lot also.
Oh yeah, absolutely.
And it's almost, I'm not sure if it's the patient is maybe just not educated as to what their actual diagnosis is, or maybe there just hasn't been time spent in establishing a more precise diagnosis. But it's my shoulder hurt, I got a shot, it felt better. Who knows why, you know, and I want it again, and I don't like that, you know. I like here's the problem, and here are the options for the solution or to treat this problem.
And you know, I sometimes get that scenario. I know we're talking about arthritis, but I get the scenario where people are like, "Hey, I want that shot, but I want to have surgery. I'm gonna have surgery. I'm gonna do it, but I want a shot to kind of hold me over because my surgery's not for a couple months. So can I get a shot now?" And I usually almost always encourage them not to do that. I'm like, look, there's multiple reasons not to, especially for like rotator cuff, which we always talk about at a different time. But the point being is, just try to avoid it if you don't have to have it. And if you but you've reached a stage where like you got terrible arthritis in your shoulder, you're bone on bone, you don't want. Okay, well, like I said, the wheels have basically fallen off the car. We'll hit you with a steroid until you're ready, right? But if it's just not working, you know, it's talking to you.
Right. Okay, quick bathroom break. Joey's going to challenge my editing skills right off of the bat on episode 1, so we'll get it. Okay. All right. So we talked about, we went over a lot of the non-operative type of things, injections, et cetera, things like that. We're going to get into the surgery options next. There really is, so I guess, the gold standard option is going to be a type of replacement surgery.
Correct.
There are some other options that aren't maybe as definitive options to help maybe more so treat symptoms and actually like give you a new shoulder joint. So touch on that a little bit with the arthroscopic options. Sure. Yeah.
Yeah, I mean, arthroscopic surgery is fancy, right? Because everybody wants the minimally invasive, like, little poke holes in your shoulder. But unfortunately, you can't do a replacement through that. And so with arthroscopic options for arthritis, there's a procedure that's kind of popularized called a comprehensive arthroscopic management, so a CAM procedure. And basically what you're doing in that procedure is going in and you're debriding the joint. You're kind of doing everything short of replacing the shoulder joint. You're trying to hit all the, quote, pain generators. The problem is the pain generator is cartilage loss, and you can't do anything in that procedure to put cartilage back in the shoulder, right?
Yeah.
So that's the thing I've never been crazy about with the arthroscopic treatment. Now, say you have a little stiffness in your shoulder, right? You might do a capsule release to loosen up the shoulder joint. That may help with a little bit of motion. Say you have some biceps irritation. You can address the biceps at the same time arthroscopically. So another procedure in that regard that an arthroscopic procedure might help. A little bone spurring or irritation of the rotator cuff. You can debride that, right? There's some things you can do, but really when it comes down to it, you're not resurfacing the joint, right? And so it's for more of those mild cases of arthritis, or you got a little bit of joint space narrowing, but the indication for that procedure, really, you still have to have some form of preserved joint space, right? A couple millimeters minimum is the way it was described and popularized by a surgeon out in Colorado. Is that you really have to have some joint space. You shouldn't be debriding a joint that's already bone on bone, because you're not going to get better.
Right.
Yeah.
Yeah. So really kind of limited, very specific indications, and probably a surgery much performed much less than actually just getting your shoulder replaced type of surgery. Yeah. Okay. All right. So let's go on to the actual like arthroplasty option. So arthroplasty meaning the joint is getting replaced.
Correct. Yeah.
So let's talk about total shoulder arthroplasty. Why don't we start off with so how do we actually get the thing in the shoulder? How about we start with that?
Yeah, so we just use a big knife and cut straight down the bone. Just kidding. Yeah, no, so so again, shoulder arthroplasty is a joint replacement, right? So you're about knee arthroplasty, hip arthroplasty, shoulder arthroplasty. It's the third most common arthroplasty, right? Is the shoulder joint. So we get it in by using an approach to the front of the shoulder. So we make a line, just what we call the deltopectoral interval. So in between our deltoid and our pec muscle, we go right in between there, and we divide between those two muscles. And deep to that is then your rotator cuff. And then we have to take down a portion of your rotator cuff to get into the joint. And then you're in the joint, right? But deep to the rotator cuff is the joint capsule. They kind of come off as a single layer. You can get in to take them down together. But again, it's deltoid, pec, go through that interval. You have your rotator cuff in the front. You're taking that down in the front.
So one tendon in the front, right? So there's four rotator cuff tendons, and then we go take the one tendon down to get into the joint.
Yeah, and then we access that. There's 3 different ways to take that down. We don't have to get too detailed there, but there's 3 ways to get into the joint, taking down the subscapularis that way. And then once you take that down and take the capsule with it, you're in the shoulder joint. And that's when you're going to be looking at cartilage surfaces.
Okay. Right. Some people use an approach, I guess it's like here on the side, like they'll split it down this way, but maybe not for like the standard shoulder.
The deltopectoral approach is the workhorse approach for the shoulder. The anterolateral shoulder approach for replacement. There's a lot of nuances to that. There's a lot of potential complications related with that. So generally speaking, the deltopectoral interval is probably generally a safer approach. Just to kind of touch on one, I mean, if you split the deltoid over the side like that, you have to worry about the nerve to the deltoid. Well, if you go in between the deltoid and the pec muscle, the nerve ending stops at the anterior deltoid. The deltoid has 3 muscle heads, right? So the anterior deltoid is already innervated at that point, so you're actually not worried about cutting through the nerve there. You're actually going between nerve planes.
Yeah, I guess we should take a moment to actually talk about the two main different types of shoulder replacements, which is a shoulder replacement that is the ball is the ball and the socket is replaced with another socket, and then those are reversed for the reverse. Right. Tell me about that.
So I generally look at one, it's called an anatomic total shoulder arthroplasty, and the other one is a reverse. So an anatomic total shoulder arthroplasty is just what you were saying, Jeff, is that you cut off the ball and we're cutting, the ball is what had cartilage on it. We're cutting it off. We're putting a new nice shiny metal ball on. Generally speaking, it's made of metal. There are some implants out where we have some altered bearing surfaces. And then on the socket side, you're replacing that with some form of a plastic, whether it's plastic and metal, but you have to have metal on plastic, just like what we call polyethylene, which is what's in knee replacements, hip replacements. So you have to have that metal surface on that plastic surface. And so that's, again, a metal ball, plastic surface on the socket. And sometimes that plastic surface on the back has a metal configuration that might incorporate into bone. Some are all made of plastic, so there's different versions of that, but generally it relies purely on the rotator cuff to function. So if you don't have a good rotator cuff and you have a torn rotator cuff, you would not do an anatomic replacement because you're still going to have your rotator cuff symptoms. You might have no arthritis symptoms, but you're going to have rotator cuff symptoms. So in those cases, or people who have reverse replacement, it's done to create a fixed point of rotation so that the humeral head, that ball that's supposed to be balanced in the socket, can balance, and then you can use your deltoid to raise your arm. So as we talked about earlier, if the golf ball here is on the tee, which is here, and you don't have the rotator cuff pulling it in, well, the deltoid is going to want to pull it up. Well, when some people hike their arm like this and try to raise their arm when it gets bad enough, and they can't raise their arm. So what the reverse does is it holds the ball, puts a ball on the socket side and it puts a cup on the humeral side, so it's a fixed point of rotation. And so now when the deltoid pulls up, it helps them raise their arm straight over their head. So it is the difference between the two is obvious for obvious reasons. I mean, one's reversed, but if you think about the shoulder joint in general, it's a golf ball on a tee, but that golf ball can translate this way, and it can rotate, versus a reverse is just rotation. So there are some limitations to motion with a reverse, specifically reaching behind your back or across your body, that is tighter and more difficult to do than you could do with an anatomic replacement that's well rehabilitated.
Yeah, so I guess for the listeners who are trying to understand the difference between the two, if you've got a good rotator cuff, you get an anatomic total shoulder replacement.
Good point. So there are scenarios. So there are scenarios though where you have a certain type of bony wear patterns where you might lean toward a reverse replacement.
Okay. There's
certain scenarios where you may have rotator cuff atrophy, not necessarily tearing, but you have atrophy of the muscle or fatty change in the muscle where you might lean toward a reverse shoulder replacement. So there are scenarios where you can have a fully intact rotator cuff but still do a reverse replacement. But generally speaking, if you have a good intact rotator cuff and you have fairly central wear on your socket, you want an anatomic replacement. If you're a shoulder purist, that's what you want, because your shoulder is going to act the most like a normal shoulder. And if you're trying to get back to, I want to swim, I want to do it, like an anatomic replacement is to me the way to go.
And then for the reverses, for those situations, but the most classic indication for a reverse shoulder replacement is arthritis with a non-functioning rotator cuff.
Correct. So what we call rotator cuff arthropathy.
We touched on earlier.
Yeah.
Perfect. Okay, you mentioned metals and materials and things like that. So super space age materials usually. Can you give quickly comment on what are some of these metals? Yeah.
So almost every shoulder replacement has titanium in it, right? Yeah. They all have titanium. Cobalt chrome is the real shiny metal. That's usually the articulating surface. So same thing in the knee, that's articulating with the polyethylene, which is the plastic, right? So cobalt chrome is a common metal. Stainless steel is not used as much in a lot of these replacements, but stainless steel is the other metal in the body we use a lot of. And so those are kind of like your three big metals in the body. But for shoulder replacement specifically, it's a lot of titanium, cobalt chrome, and then polyethylene is the plastic. Now there's treatments that are done to those plastics. There's a certain amount of cross-linking that they do to make it. There's high molecular weight. There's highly cross-linked poly. There's polyethylene with vitamin E in it to decrease free radical. I mean, we're getting into a lot of details, but the point being is it's a very fancy plastic, very fancy metal, and they're articulating with each other.
That's kind of what I wanted to touch on, because I hear this loosely turned, we're going to put some metal and plastic in, and then immediately in my head I'm thinking of the Rubbermaid Office Depot container plastic, no, this is
and so it makes it sound cheap. People
exactly.
wonder about costs. I know we were talking about this one day. If you ever have, and I've fortunately had the ability to go to a plant tour, right, and tour where these implants are made for one of the companies I use, and it's you very quickly realize why these implants cost so much money, right? They're not cheap. You know, a shoulder arthroplasty could be, you know, the actual implant could be anywhere from $3,500 to $7,000 or $8,000, right? That range. But those implants are so well manufactured. They're cared by so many people, have to touch them to bring them to up to speed. Like I literally watched, you know, a person with a large magnifying glass and the implant in their hand, you know, gloved hand, and they're taking an instrument and they're cutting the lines in the porous coating on the implant. Like it's literally done by hand. And this is one of the touches that has to be done to make these implants, right? So they're in these significant, you know, these machines that are like buffing the surfaces to the smoothest because you don't want any imperfection. You have an imperfection in the implant, you'll tear up, you'll cut into your polyethylene, you start to create an inflammatory reaction in your shoulder, your implant loosens, right? So it is highly manufactured, it is highly detailed, and then they have to go through a sterilization process, which is not just like, oh, pop it in there, it's done. It's like here's this section of the sterilization, here's the next. Some get shipped out to get sterilized and come back. Like there's so much that goes into making an implant. So you wonder why healthcare costs so much. I mean, you got to pay for all that stuff, right? Pay for the person, every person who touched it. You got to pay for the shipping. You got to pay for. There's just so much that goes into it. So yes, it is expensive. We're fortunate the United States have access to some of these great things that we do because a lot of countries do not have access to shoulder replacements like we have here in the United States.
Right. Yeah. I think that's an excellent point. There's a lot of really skilled people that are part of this entire process. The people at the facility that make it, once it arrives at the hospital, the surgeon who puts it in, and the people at the hospital, the scrub techs, the instrumentation utilized to actually that you use to put the implant in, all that. There's just so much that goes into taking care of just one person. I mean, let alone the thousands that go in. Okay, and then so how do you actually how do you implant the components into the bone? Like, how does it actually seat into the bone?
It's a good question. So on the socket side, so we have, so as you mentioned, we have instrumentation, right? So all these implants, you can't just like look at the bone and stick it on, right? You have to physically create the receiving site for the implant, right? So all these companies have different instrumentation to create, you know, for example, if we do an anatomic shoulder arthroplasty, we're putting a plastic piece on the socket. Well, generally speaking, there's a peg component and there's a keeled component. Keeled are kind of a thing of the past. They still can be used. But generally speaking, on the backside of that kind of pear-shaped or whatever shape your socket piece is, you'll have pegs. And those pegs can be made of metal. They can be made of plastic. And a lot of times it will require some form of cementation. So we'll actually prepare the sites with guides, drill holes in the bone, and there's oftentimes a significant interference fit with that implant to create some rigidity and to decrease micro or any kind of motion with that implant, and then we'll cement into those holes and impact it in. Let the cement dry, cements in.
And that's on the socket side.
That's on the socket side. On the humeral side, it would be you're taking the head cut off, you're looking at the head cut surface, and a lot of implants have changed over the years. So for anatomic arthroplasty, we've had stem components, which are kind of a standard stem that goes in the canal. So you'll prepare the head cut, but then you'll create a hole that communicates with the bony canal, the medullary canal, and you'll put a stem that goes into that canal. Well, those stems have gone from conventional stems, which are a little over usually like 10 centimeters or so, to short stems, which are about 40 to 50 centimeters usually, so much smaller. And then now there's stemless implants. And that's typically what I lean toward for an anatomic arthroplasty. And what stemless means is I'm looking at the cut surface, and all I'm doing is creating a little receiving site on that cut surface for whether it's fins or whatever it may be on a little what we call a little kind of, it's like they call it a stem, but it's just like a little stemless, meaning it's just like engages the bone up there. If it's good bone, it has porous coating on it, it can ingrow into that implant. But the reason that stemless is so nice is people think, well, it's just a ball on a stick, right? That's the humerus. Well, no, actually, the humeral head is not sitting right over the shaft. It's actually set back a little bit, and it's what we call retroverted, tilted back. So if you imagine, I'm going to put a stem down the canal, but that stem is going to dictate where that head can go, right? So you actually, stemless are advantageous because you don't have to worry about where the canal is at all. You cut off the humeral head, you put the ball where it's supposed to go. So you're looking right at it. So you can size it perfectly, and you can put it right where it needs to go. So sizing when it comes to stemless is much better and more straightforward. And then if you ever have to revise it, you have more bone up there to work with. You take the stemless out, you're getting bone is the commodity, right? You lose bone, you can't get it back. So you want to preserve as much bone as you can. So for me, my primary arthroplasty for an anatomic is a stemless arthroplasty. 100 times, out of 100, if the bone can receive it. If not, I go to a short stem.
Yeah. Okay. So, all right. So so typically on the humeral head, We are talking about more likely a press fit, friction fit, and then cementing still on the glenoid, the socket.
So there's not to give you too many details, but there's on the socket side, there's typically all polyethylene, which is all plastic. There's a hybrid, which is part plastic and part metal components on that plastic. So some of it might ingrow to bone, and some of it might some of it has to be cemented, so kind of a combination. And then there are metal back components. Some of the earlier metal back components had really bad failures, and so when there were failures, it was very dramatic on the glenoid side. So they kind of fell out of favor. They are starting to resurge a little bit, and the newer metal back implants are showing potentially lower revision rates than in the past, and more comparable to some of what we call an all polyethylene or all plastic cemented component. But the tried and true kind of like that's been out there for a long time is an all polyethylene plastic cemented in implant, right? But there are different or iterations out there. There's kind of those three.
So for the standard, just like I've got shoulder arthritis, really no other significant issue going on.
Yeah.
You're cementing that in, press fit on the head.
Yeah. Okay. And press fit, maybe what does that mean? That means we're preparing a site that's slightly smaller than the implant. And so we engage the implant and it actually gets a press fit, actually is almost compressed into the bone. And there's porous coating. And what's been found over the years is that bone will grow into certain size pores, right? So the porous coating is designed such that bone can grow into it, and eventually when that bone grows into the porous coating, it is rock solid. Like it should not go anywhere.
Excellent. And then a little bit different for a reverse shoulder replacement. More metal backed. You've got screws going into you actually use screws to fix into it. So a big difference there.
So there's screws and posts. And so on that side, you're preparing the socket. You're either putting a post base plate implanted or screws. A lot of people have gone to screws because they get more compression. And so we like compression in orthopedics. So when you have porous coating on the back of something, you compress it into bone. It's more likely to ingrow. And in those scenarios, so generally we like compression. So there's a lot of screws that either help you compress it down, or then there's peripheral screws that you lock into the bone. But the whole goal is for the bone to grow into that implant, just like we talked about. And if the bone grows in, base plate failure rates are exceedingly low, like 2% or less, maybe 1%. I mean, and so interesting though, you brought that up is because the way that anatomic shoulder replacements fail is typically on the socket side, right? Though that plastic piece and cement mantle will loosen over time. Versus a reverse does not have that problem, right? That porous coating in the backside of that implant, if it grows into it, the likelihood of that failing is really low.
Yeah, that actually reminds me of something I meant to, maybe we did touch on it, but I'll mention it again earlier about the integrity of the rotator cuff with an anatomic standard shoulder replacement. Because if there's an issue with that, just like when a normal shoulder, you don't have a rotator cuff and you get that ball sliding around in the socket, you can eccentrically, or let's say put pressure. Yeah, you can put more pressure on one side than the other side,
right?
And then it can start wiggling itself out.
Right.
Yeah.
And that's why the best patient for an anatomic arthroplasty is the one who comes to see you who has bone-on-bone arthritis, but you look at their axillary lateral X-ray and they're literally it's like the golf ball is just eroding straight into the tee, right? It doesn't look like it's wearing on the back or the front, just right down the middle, because you know that when you replace that shoulder, they're going to wear right down the middle. And the ball, their central nervous system says, this is where my humeral head's supposed to be, right? Yeah. And so that's and if you look at studies, patients who have that type of glenoid, we call it an A glenoid, they wear right down the middle. Those patients have the longest lasting anatomic arthroplasties because their glenoid component does not fail as quickly.
Right. Okay. So we've got a diagnosis of osteoarthritis. We've decided we're going to get our shoulder replaced. There's a lot of stuff on the surgeon side that we're thinking about, what kind of implant, how we're going to get it in, etc. But what can patients do themselves to maximize their chance of success, getting through this surgery successfully?
Listen.
Wow. Good. Yeah. Good one. Make note, patients.
Listen to this and listen what your surgeon has to say. And if you do everything that they ask, generally speaking, the surgeon's not trying to steer you in the wrong direction. And again, if you go to 6 different surgeons, there's going to be minor tweaks to everybody's post-op protocol. But if the surgeon tells you need to be in your sling, you need to wear it, there's reasons for that. And I will tell you, there are some surgeons who will let people go right away with a reverse replacement and be like, well, look, I don't have to repair the rotator cuff in front if I don't need to because it's constrained around this ball. They can go start using their arm. There's some truth to that in some scenarios, but I would tell you the reasons I don't like to do that is because, one, I want your wound to heal without any problems, because if you get an infection in your replacement is a nightmare, right? And everything you thought it was going to be, it's not going to be, right? So that's number one. Number two is a reverse replacement, for example, can become unstable. And so if you have a ball in a cup and you just start doing too much with it, well, we developed all these soft tissue planes when we went into your shoulder. Well, we want some of that to tighten back down, but if you don't give it a chance to, then your shoulder could be loose and it could pop out of socket. So instability with a reverse shoulder replacement typically happens in the first 6 weeks after surgery. So if you're not doing what you're supposed to do and you're just using your arm like crazy because you have this mechanical advantage, all of a sudden you can raise your arm, you might have that problem, right? So that's another thing you have to worry about. On the anatomic side, though, if you're not wearing your sling and you repair that muscle back in the front, and what did we say earlier? You are 100% relying on your rotator cuff for that to work. If you don't let the rotator cuff heal back, you're going to have a failure. It's an early failure, subscap failure. Humeral head's unstable out the front. It's going to go out the front door because the front door never stayed closed, right? So listen is kind of, so all I can summarize to just listen.
Number one,
post-op instructions, follow them to a T.
The formal term we use in medicine is compliance.
Compliance,
right?
And
compliance,
and avoid reading all the stuff on
You're
Google.
leaning into the mic as you say it to make sure everybody hears it. Okay, so that's number one, and then of course, in terms of like medical status, are you diabetic? Do you have these other things? Is your blood pressure really high? All these things that can be modified. Is there anything along those lines that you pay attention to? Smoking,
absolutely. So smoking is a hard stop for me. I do nicotine tests. Smoking increases your risk of infection. It also increases risk for failure of soft tissue healing, right? So what I tell every patient is so nicotine, it causes your blood vessels to constrict. Well, if I said, well, there's that fire over there, the house is on fire, here's a garden hose, go put it out, good luck, right? I mean, the house is going to burn down. So you need blood flow to heal. You also need blood flow to deliver antibiotics to an area, which in surgery we're giving you antibiotics to prevent infection. So if you don't have good blood flow to an area, then you have a higher risk of developing an infection. And remember that as much as you make things, quote, sterile in the operating room, there's bacteria everywhere, right?
Right.
And so the idea that there's this completely sterile environment where there is no bacteria is just not true. It has to do with your immune system, how much you can suppress bacteria and fight off infection, how much blood flow you have to an area so you can deliver antibiotics and heal, right? So it's all tied in. So smoking is a hard stop for me. I do nicotine testing. I want you stopping probably 4 to 6 weeks ahead of time. And our hospital actually where I work has a hard stop for that too, for all joint replacement. Diabetes. Diabetes is a small blood vessel disease, right? If it's uncontrolled, and it's, everybody follows that number. Hemoglobin A1C is a common number. It's checked. It gives you a reflection of how your blood sugar's been doing over the last 3 months. If that's high, and there's, classifications for that as to what's high, but that number gives you a reflection of how your blood sugar's been doing. If it's on the high side, oftentimes we'll want it to come down, right? And a lot of times you see these things coexisting with other problems like heart disease and some of these other things. So you might need a clearance from your cardiologist. You might need to stop your blood thinners if you're on blood thinners, which a lot of people are. You might need a clearance from your primary care. So generally we're getting multiple clearances from multiple providers for quite a bit of these patients who have replacements because they tend to be older and they may have other medical comorbidities.
Okay. So I think that's essential information. And really, the surgeon, the doctor, and all the medical people, they're working as a team with the patient to achieve a certain goal, right? And that goal is a great outcome and a shoulder that feels great to the patient. And so it's just not all on the physician side to ensure a successful outcome. You gotta be healthy, you gotta stop smoking, all these things. I think it's just great to emphasize that 100%. Okay, so let's talk a little bit about after surgery. Okay, so what do you so are you keeping people overnight in the hospital? What do you do?
It's a good question. Well, as medicine has evolved, you'll see a lot of people trying to be sent home, the same day, like same day surgery, right? What maybe somebody had told me years ago, they may stay in the hospital for a week. Now they're going home the same day without even staying overnight. For shoulders, I still like to keep people one night. I do like IV antibiotics for 24 hours. I'm a big no infection type of person. So for me, I try to avoid the biggest risk, or the biggest, the risk that could cause you the worst outcome. So for me, I like the IV antibiotics for 24 hours. I also like that, for surgery, you can have a nerve block to kind of numb your shoulder. And that nerve block can last several days. However, there's two medicines usually that we use, and one of them is shorter acting. So when that first one starts to wear off, people tend to notice the pain starting to come on a little bit, and you can get behind. And if you get behind at home and you don't have maybe IV medicine that you can quickly give somebody to catch them up, they can be in a lot of pain. So I like that transition. That transition is usually at about 24 hours. So for me, I like to operate, keep them overnight, see how they're doing the next morning. They're starting to have that first part of the block wear off, make sure they're transitioning smooth, and then I get them home.
Let me ask this question.
Yeah.
Have you ever regretted keeping a patient overnight?
No.
Have you ever regretted having a patient go home too soon?
Well, yeah, so it's funny you mentioned
Right.
that. In my entire practice in 8 years, I've only sent 2 people home with shoulder placements the same day. And that was during COVID when we were not allowed to admit patients to the hospital. And I told the patient, I cannot admit you after surgery. This is not my standard practice for replacement. But if you're adamant that you want your surgery now, you'll have to go home after surgery. And they said, okay, because there were no beds.
Yeah.
And so at the height of COVID, there were no beds and they went home. And I will tell you that one of the guys who did was like in his early 50s, I believe. And he told me, he's like, man, I wish I'd never had to go home. He said it was miserable. And so, from that experience, I was like, I have no reason to send people home. Right now, it is trendy. I will tell you, there's people who are going to try to do these in surgery centers that have no overnight stay. It's kind of a big push with depending on the way the healthcare is going. There's some probably financial benefits to those surgeons maybe doing it that way. Just to be transparent, I mean, that's the truth. Is that if they can make things more efficient, it's more cost effective, right? Then they say, okay, well, this is bad, and so they streamline it and they do it right. But it's got to be a well-oiled machine, and they got to have it done right, because you can't just kind of say, oh yeah, come on in to the surgery center today, you're going to send you home. And generally, the people who are doing it that way should, and if they don't, they should, because this has been studied, they should have that down to a T, very well streamlined, so that you're not in these scenarios that we talked about.
Yeah, going back to the nerve block for a second. The other thing that can happen is part of the nerve block can actually get part of one the nerve to your diaphragm.
Yeah.
That can that makes your lungs function. And so if that happens and you start having some breathing issues, you can just kind of see where that might go. Especially if you've had some pre-existing lung problems and maybe it was not recognized initially or something. You might be doing okay, and you say you didn't go to PCP or for whatever reason, and you don't want to recognize that when you're home at 10 p.m. and you can't breathe.
Right.
No,
it's scary.
Yeah.
And that's another reason I do like to keep them.
Right. Yeah, that was exactly.
Yeah, they do the next morning. We got to wean them off oxygen, and it's a real thing. I tell every patient this too, because I want them to understand that. I'm not to discount that the anesthesia team doesn't do this, but sometimes they're moving quickly, and I don't think enough emphasis gets placed on this will affect your breathing. Like, you will feel like you were short of breath. Like, you might walk to go to the bathroom and you'd be like, I do this every day. Why can't I breathe doing this? But just the minimal amount of exertion may cause you to be short of breath, and that's scary for people. And there are scenarios over the years, I've probably had a handful of patients, maybe 2 to 3, up to 5, maybe even, that have gone home with oxygen because they could not wean off the nerve block. It was there for 3 to 5 days, and it just wasn't. And so they're either going to stay in the hospital for 3 to 5 days, or they're going to go home with the oxygen, right? So we've had to get them approved for home oxygen. So it is a real thing. So if you have bad lungs, so say you don't smoke, right? You stop smoking, but you have COPD. And you can't, and you have breathing issues, you're not getting a nerve block. So your pain management around surgery is going to be much different than the vast majority of patients having a shoulder replacement, or most shoulder surgery now is done with a nerve block present.
Right. Excellent point. And then I'll make one final one as well. I think this is just a little again, more on the patient education side. I always warn people about that spike when that nerve block starts to wear off. And I guess it happens differently. Some people it happens rapidly. Maybe it's a slower on. But patients have to know, hey, look, this is the typical duration, and it's not like on the second the nerve
Right.
block wears off. It's kind of this slow process at different rates of increasing pain, and you just got to know about that ahead of time. It hits people differently too.
Yeah, it really does.
Okay, so all right, how do you rehab your shoulders after surgery?
I'll start with reverse. So reverse, I typically do 6 weeks in a sling, and I don't do anything other than elbow, wrist, and hand motion for the first 2 weeks. I start with pendulums at 2 weeks, and then at 6 weeks we start stretching. And stretching means like overhead, right? Stretching up, forward elevation, external rotation. Behind the back, you avoid a little bit in reverse because it is potentially a position of instability. So early on, we're not really pushing that. As far as anatomics, I do move those a little faster. I find that when you start them a little bit sooner, they tend to be less risk for stiffness. But there's time in my practice where I do start them at 6 weeks, and a lot of people do fine with that as well. The reason I like to start a little bit later for that is because that muscle in the front, the subscap, whether you take it down with a bone piece or you take down just tendon, that's got to heal. And if it doesn't heal and you push on it too hard too early, you can have really subscap failure. If you go in and try to repair that early, the likelihood of it healing that second time is much lower. So I try to avoid having a subscap issue. So for me, I'm a little bit slower probably than some as far as moving their anatomics, but I do start around week 4 to 5 with passive motion stretching. But I'd also like to make sure that piece is healing well.
Yeah, that goes back to the compliance thing, especially early on, it seems, with some of these cases. And it's hard. I get it. It's hard for patients. You got to be in a sling for forever. You got to sleep in it. You got to. It's just it kind of messes with their head a little bit, being immobilized for that period of time. But there is a reason for it,
right?
And following those instructions early on can really help minimize big problems down the road, for sure.
I mean, that's a great point. I think there's definitely a reason for it. And I know it's miserable to be in it, but if you listen and you go and you do it, like we talked about earlier, you're likely to benefit from that.
Yeah.
And then once you're out of the sling around the 6 weeks, you're starting to progress. That's when people think more about the therapy that probably comes to mind, like I'm doing some strengthening, I got some bands, I'm doing that type of thing. But typically the timing is what's important, I think, as far as the therapy.
So when would you say, like, what's kind of the range when you're thinking people are getting, feeling like 90% there? Like, how far out?
So everybody improves up to about a year. Some people between year 1 and 2, and after that, it kind of peaks. And
improves, like they're showing steady improvement to a year.
Steady is there is improvement. Steady, I guess, is depending on what you mean by steady. Meaning you'll get better, but the better you get, the room for improvement is much smaller, right? So you should see the general trajectory improves all the way up to a year, and they tend to plateau a little bit. But between year 1 and 2, you'll tend to notice just a little bit better. And there's actually some evidence that maybe after year 2 there's some slight decline, but generally speaking, year 2 is kind of where you're maxed out, and you're kind of holding that pattern hopefully as long as you can.
Okay, let me just say that again so I understand everybody else does. From day 1 after surgery up to year 1, you're probably getting your most substantial gains after surgery, and then that slows down substantially, but maybe not completely. Correct. From year 1 to year 2.
Yep.
And when would you say patients are getting to about, I'm feeling 90% there? I feel like I hear that from people. Yeah. They use that 90% level probably, to kind of like that's where they're feeling good. I'm about 90% there.
A safe answer is about 6 months.
6 months. Yeah. Okay, 6 months to 90, then up to there. Yeah. Okay.
Like at 6 months, I'm like, go do what you want to do for the most part. If your motion looks good and your strength's pretty good, you're probably, and your therapist usually discharging about 5 months out, 6 months out. Reverses may rehab a little faster because it's a little more forgiving. Like if you have an anatomic, you're probably going to be maybe doing therapy a little bit longer, because generally speaking, your goals are, a lot of those people may be more active and have different goals.
Got it. And let's talk about weight restrictions after doing a shoulder replacement. So there's a guy at the gym that I think he had a standard total shoulder, and he works hard at the gym.
Yeah.
So what are you telling people? Hey, just do whatever it is, work up to whatever you want to work up to weight wise, or force that you're going to transmit through this joint, or you're like, nope, 50 pounds, you're done, no more.
Well, it makes us feel good to tell people don't lift a certain amount of weight, and there's a reason for that. I mean, but honestly, I know a lot of the big name guys out there on the podium, and there is no evidence that you can't lift what you want with your replacement. However, almost every person, when asked, has a weight restriction that they give their patients, and the part of the reason that is is because they are small components. We do want it to last as long as possible. We want it to be in there as long as possible, because if you have to revise it at some point, if you're young enough, revision surgery is not straightforward, and there's a lot of ways it can go wrong. And revision outcomes are not as good as primary outcomes, which means we want that primary implant to be in as long as it can. So if you tell us, hey, look, I have this little plastic piece I'm going to cement on this socket, and now you're going to go bench press 350 pounds and edge load that implant, for 10 straight years, that implant's going to fail very quickly. Right?
Yeah.
So you just have to be reasonable about what you do, and you have to understand that. And so if you're having so in those patients, generally speaking, we wouldn't do that. We'd probably just replace part of the joint, like the humeral head part, do what we call hemiarthroplasty. So you just have to be reasonable about it. I tell my patients 25 pounds. And generally what I mean by that is I'm okay picking up to waist height. I mean, like if you're extending your arm with like 25-pound weight out here, pushing on stuff. And
max torque. Yeah.
Just generally speaking, live around that or less. If you happen to load it a little bit more one time, that your implant's not going to fall apart. But you try to minimize those significant loads.
So that 25-pound number that you use, that's sort of this sweet spot where you're trying to keep people out of trouble long term.
Right.
And it's you drive a car hard. I drive a 4Runner. I'd like to take it off road more often. If I did and banged it up, it's probably not going to last as long as if it's just a pavement princess.
Right.
It's just going to,
Right.
And so same thing applies. So there's there's I guess different answers to that based off of who you talk to.
Yeah.
Okay, so let's go through some different activities, and you just tell me what you expect. So tennis. Can I play tennis after this surgery? Yes. Okay. What's my game going to be like? Not as good? I'm not going to serve as much?
So I think it depends probably a little bit on the implant. So like I said, if you have an anatomic arthroplasty and you rehab that thing back to like a normal shoulder, you can probably do just about any activity.
Pretty good?
Yeah.
What about golf?
You can golf with both.
Yeah.
So tennis, like an overhead serve, to cock your arm way up and back with a reverse, it may be a little bit challenging in that scenario because of the constriction of the implant. It's constrained to a degree.
Yeah.
As I mentioned earlier, remember, reverses just rotate on the ball. They don't have that translation effect, right? If it's translating, it's going to come out of socket, right? So you don't want that. Right, so a reverse is going to be a little bit more restricting with certain movements, but generally speaking, yes. What you asked, golf and tennis. Yeah.
Should be good to go with tennis. Should be good to go with golf. Swimming,
to a degree, yes. Yeah, I mean, you might that end range might not quite be there with a reverse.
Right. Yeah. So a lot of the activities that probably the typical patient in their age group, I'm going to say 50s, 60s, 70s.
Yeah.
So the type of activity sporting that they're going to be doing, you're probably going to be just fine.
Yeah.
The tennis, the golf, the swimming, the low impact type of things. Trying to think of another type of activity that maybe somebody would do. I don't know, basketball, probably fine, I would guess.
Yeah.
I guess nobody, I would be surprised if a 50, 60 or 70-year-old is playing football. Flag football, maybe. I don't know.
That's a red flag.
Baseball, softball, probably should be good. All that kind of stuff, huh? Okay. Okay, let's talk. This, I guess, this could be one of our last topics. Let's talk about like longevity.
Sure.
Okay, so we've touched a little bit on longevity, and in particular, minimizing strain on the implant to make it last as long as possible. What are you normally quoting patients in terms of how long is this thing gonna last?
Typically, like an anatomic is 85 to 90% at 10 years.
Okay.
There's some data would say it would last longer, maybe 15. But be thinking like in that 10-year ballpark is when things might the wheels might start to fall off. Maybe a little before, maybe a little later, but you might start noticing some stuff there if it's well done and it's in the right, well indicated. A reverse is about 90% at 10 years. There is some European data now that maybe or overseas data rather that they're looking at some of their older implants, which were designed a little bit differently, but they were reverse replacements, and they were actually about 75% of people having them at 20 years still have their implants in. So reverses are probably going to outlast anatomics, truthfully, when it comes down to in the grand scheme of things, we're able to follow reverse replacements long enough. The newer designs, right, which are just a different concept, which is a little more detailed, but they're probably going to end up outlasting the anatomics in the grand scheme of things.
So how much of that do you think is because maybe this is incorrect, but how much of that is because the patient that you're putting a reverse in tends to be older and less active than someone you're putting a typical standard replacement in?
I think the thing that reverse does, right, is reverse solves the glenoid side of the problem that anatomic has, right? That anatomic component is going to loosen on the socket side. We know it. That's the number one reason for failure. Rotator cuff tears are number two, long term. So if you solve that problem with a reverse, and your plastic piece on your reverse is so well made now that the likelihood, however many millions of cycles it can go through before it's really wearing, the longevity of that implant, if it ingrows to bone and there's no issues with infection or other complications, the likelihood of that failing is pretty low, right? So that's where reverses are probably going to outlast anatomics, right? Versus an anatomic, until you solve the holy grail of glenoid loosening, right? We're always going to see glenoid loosening to a degree. And that's the reason that they're going to fail long term.
Okay. Yeah. Well, so say you got a 40-year-old, whose shoulder's gone. Are you going to, they're going to be on that, I think, what did you say, like 80 to 90% of 10 years? They're going to be closer to that 80%.
Yeah. So they're going to
especially if they're not abusing.
So age under 55 is a risk factor for increased or earlier failure.
Yeah. Okay. And I can imagine a 40-year-old is still wanting to put 2 plates on the bench. And want to do stuff like that, which is.
And I love Jerry Williams' quote. He was on the podium once at one of our meetings, and he's a huge shoulder name and up at Rothman in Philadelphia, a huge orthopedic program. And he was former Academy president, Shoulder Elbow Society president. He walks in, he tells the patient when they're young with arthritis, he looks at their X-ray and he says, "You have a problem. You have arthritis in your shoulder. This problem sucks." He's like, and guess what? All the treatment options we have for it suck too, and we have to choose which one sucks the least for your shoulder. So meaning. Arthritis in the shoulder is a really bad problem to have when you're young, because the implants we have do not last forever, right? And if you have a replacement at a young age, you're going to have another replacement and maybe another one, right? And so, as I mentioned before, you revise that implant, the likelihood of you having a revision outcome that is better than your first is poor, right? And so every time you hit it, it's less likely to be as good, right? And then every time you hit it, you're losing bone. And when you only have this much bone to work with to start, you have very little bone to work with as it keeps, implants start coming out. So again, I love that quote because it's the easiest way to just get it, right? Like, if you're young with shoulder arthritis, it is a bad problem, and there are good treatment options for arthritis, but they are bad for young people, right? And that's kind of, it's been a lasting effect on me.
Yeah. So if you do have a young person who's less than 55 and they're having some pain, and it seems like you're really trying to get that person to 55. Without a shoulder replacement. Right. Through any one of these non-operative things that we've discussed. We're managing symptoms. We're maybe, we're considering PT if they've got some early arthritis. We're doing shots to manage symptoms. And one thing, I don't know if we talked about this earlier, but even like some of these lifestyle considerations, do you need to bench heavy? Do you need to do certain activities that really make your shoulder hurt? And can you limit those activities, but still find fulfillment in whatever it is you want to do?
Right. And and it's like we talked about in the past too, that, I've modified my lifestyle. What I did at 18, I don't do anymore. Right. I still exercise. I still go to the gym. I still do cardio, and I do more of the stuff that's less likely to negatively affect my joints than I did when I was younger. I'm like, it's almost like an ego thing. Well, I just want to lift really heavy because look how much I can lift. Yeah. Well, that's great, but what are we accomplishing by doing that? Right. I mean, are we competing? Is this for a gold medal? Right. Like, what are we, be truthfully, like, what are we doing? Right. You don't need to train at that level and that high amount of weight on your body to look good. Right. If you're trying to get fit. Right. I mean, we know that there's so many factors in that, diet and, cardio. I mean, there's all kind of things. Right. So you have to sometimes say, well, look, my shoulder hurts really bad, or my back hurts really bad, or this hurts really bad. But when I do this, it makes it worse. So if I do less of it, but I choose to supplement, what I used to do with something else, that still gives me that fulfillment of, hey, I'm still competing, or I'm still hitting that competitive drive that I have, or I'm still, fulfilling, a physical activity just in a different way. That's kind of what you have to, I don't say have to do, but you should consider doing. And that's kind of what helped me change over the years. Was I like to golf, but I also used to like to lift heavy weights. But when I squatted really heavy weight and then I went and played golf, my back was killing me all the time. So I stopped squatting really heavy, and my back never hurt when I played golf. So I said, well, you know what? I'm not going to squat anymore. I just do other things to strengthen my legs and my core without just taking a bunch of weight and compressing my spine down on itself, right? And so it solved the problem, right? So for me, it's like, well, now I don't need to worry about my back so much because I still get fulfillment doing all these other things, and I enjoy golfing, right? I'd rather be able to go do that than say, oh, I just put 1 million pounds on my back and did it once and I feel like such a man, right?
Yeah.
So that's just kind of the way I think about it.
Yeah. I think that's great advice, man. Well, look, we've gone over, but really appreciate you taking the time. I think we've hit on a lot of stuff, and I think a lot of this information is going to help a lot of patients out and just really kind of understand what they're dealing with and understand the treatment and everything. So really appreciate the time, man.
Yeah, absolutely.
Thank you very much.
Yeah, thank you. It was awesome being on.
All right.
All right. Boom.
Boom. That's a wrap.